Good afternoon, everyone. I would like to welcome you to the Northwest Seminar Series in Mathematical Biology and Data Science. The seminar series is co-organized by the University of Manchester, the University of Liverpool, and Liverpool John Moores University. This talk is hosted by Liverpool John Moores University, and it will actually be the last lecture that we have this year before Christmas. We will restart in 2024, sometime late January, probably. Today's lecture will be presented by Professor Lucian from the Universitatea Transilvania Brașov in Romania. And I would like to thank you all, just because it's the last talk before Christmas, for attending this seminar in the semester. And yeah, I hope you will stay with us in 2024. I would like to introduce Lucian to you. Lucian, you studied systems engineering at the Transylvania University of Brașov. I think you then stayed there for a PhD, also in systems engineering, and you worked on computational modeling of blood flow using high-performance computing. During your PhD, you already collaborated with Siemens in the US, and you apparently developed then, as far as I can see, an interest in artificial intelligence. And now you are a professor at the University of Brașov, and you have kept a relationship with Siemens. You are at the moment the director of the AI department at Siemens in Romania. So I have seen that you are primarily interested recently in digital twins. And I have to say, I would really wish very much if my digital twin could have caught my cold. So I will stop speaking now. And I look forward to your presentation on artificial intelligence in personalized cardiovascular medicine.
Yes. Hi everyone, and yeah. First of all, thanks so much for the invitation. Very happy to talk about AI in specifically in cardiovascular medicine, but in general, on our activities of applying any AI in healthcare. So, yeah, as Ivo was saying, right, I have a double affiliation, both the university and Siemens, and here I'm. Of course, we have a lot of internal projects funded by Siemens, also EU projects, national projects, so publicly funded projects. So basically what I'm presenting here is, let's say, a combination of both Siemens internal projects and publicly funded projects. And at Siemens, basically, we're the group in Romania, we're part of a, let's say, global group, which has the headquarters in Princeton, and we're working very closely with colleagues from all over the world to develop proof of concepts, and of course the final goal is to bring them to products, to really help the patients in everyday situations and in routine clinical practice. So before going into, let's say, examples and concrete applications, I wanted to first present an overview of how AI is being perceived and applied at Siemens. So basically, you can see here different levels of where AI is being applied, where we start from a level of low complexity, low difficulty in integration, and when we move upwards, you can see that complexity and integration are increasing. So if we talk at the lowest level, basically this is the level where medical data is being generated, right? So if we talk about the medical scanners like CT and MR, data is acquired by sensors, and then starting from this data, you have to generate medical images, which are being then analyzed by clinicians. So basically, in the process of generating these medical images, we already use AI to make the data generation itself more efficient and of higher quality. Then if we move up to the second level, basically I think this is the level where AI is very heavily used at this moment and mostly used. It's the level of reading and reporting, where basically you have the medical data, you have the medical images, for example, and the goal of AI is really to help the clinician in measuring and quantifying and detecting and segmenting and doing all of these, let's say, quite basic processing on the medical images to extract quantities which then can be used by the clinician in the decision-making process. If we move upward, the digital twin, which was mentioned before also by Ivo, this is already at the patient-centric level. So it's about bringing data together around the patient, so from different sources. It can be from in-hospital, out-of-hospital, smartwatches, medical image scanners, ECG, whatever, right? So all of the data that can be gathered around the patient to create a digital twin. And typically at this point, it's no longer just AI, right? Which is basically statistics. It's also about coming with computational modeling, or basically physics-based modeling to interpret the data, to model the data, to basically simulate different treatments and so on. And I'll get back to this point later on. So I would say these are the three main levels where AI is of interest at Siemens in the research and also in the product development. And there is, of course, also a fourth level, even higher up, which refers to population health management. So here AI, of course, could be used very efficiently at regional level, at country level, for governments or authorities to basically understand different health directions or health trends that appear in the population, like increasing obesity, having cardiovascular diseases at a lower age, increasing in cancer rates, and so on. So basically understanding all those trends in the population and trying to come up with different strategies, different policies to counteract such trends, and basically, of course, with the goal of increasing the overall health health of the population. Now, right, I'm gonna, as the title was saying, I'm gonna refer during this talk mostly to cardiovascular diseases. Of course, at Siemens we're using AI and medical data in all the different fields, right? Like oncology, whole body, even non-medical imaging, and so on, right? But also given my background, as Ivo was saying, right, I had a background in computational modeling during my PhDs, and then when AI became more popular, we combined it with AI and switched to AI. But as a topic, I always was involved from, let's say, from a medical point of view in cardiovascular diseases. And basically in cardiovascular diseases, the single most important disease or cause of death is coronary artery disease. So the coronary arteries are basically the arteries which supply the heart with blood. Basically, this is, you can see here a laid out view where we have the heart, we have the aorta, and basically these small arteries are the coronary arteries which supply the myocardium. So basically that's the muscle of the heart with blood. And one of the goals here is to understand and to detect coronary artery disease. So basically coronary artery disease means that you have some deposits of different material. It can be fat, it can be calcium, which basically reduce the blood flow to the heart. So basically what you can see here is the inside of the vessel. This is a contrast agent is used such that you can then see where the vessels are, and basically we see here the interior of the vessel. So normally this should be a tube with a constant diameter, but you can see that actually it is decreasing at some locations, which means there is a deposit of some sort of material which reduces the blood flow, and of course in extreme cases this can lead to infarction and to reduced quality of life and so on. So one of the goals of the developments we've had was really to be able to quantify these lesions anatomically. So the first goal was really to detect them, and you can see here like a lesion on the RCA vessel with the proximal location, the location of the minimum diameter, and the distal location, which was trained on a very large number of stenoses. Of course, once we have these detections, but the final goal for us would be to basically present a report, right? So the patient is referred to CT angiography. That's a very now standard non-invasive test when the patient is suspected of having coronary artery disease. The physician orders such a test. The test is done, and then we can come with the software and basically automatically analyze the data set, the CT angiography data set, and the goal is to prepare a report, right? To show to the clinician, look, there is a lesion here. It's so and so severe. It has these properties, and so on. So be able to generate this report. We also need to do an automatic labeling of the vessels. So there is a standard in the domain where each of these segments, you see them here numbered, each of these segments has a name, and then for us or for the AI model, the goal is to be able to label all of these segments to then generate that report, right? To be able to say, okay, on segment 1 of the RCA, so that's the proximal RCA, we have a lesion with a certain reduction in diameter and a certain severity. And if we have this detection of the lesions, if we have the labeling, we can generate such a report. Basically, such a report, and there's a scoring system which is very popular in the analysis of coronary CTs. It's called CADRATS, and which will tell you the severity of the coronary artery disease. And I'm showing you here basically a software application. It's a prototype at this point, which shows you exactly those findings, right? So we have here the overview of the patient with the different vessels. It will tell you that the classification is CADRATS 2. So basically, that's a not very severe type of disease. We can see here all of the labels and with different color codings from normal to occluded. And then we can switch to a segment level view where we can see for each segment, you see here the different segments that I was mentioning with all the names. And for each of them, you will see how severe the lesion is. And then you can go into an even more detailed view where for each lesion, you see different properties. What's the minimum diameter? What's the minimum area? What's the length? If it has different vulnerable plaque features, that's a very important characteristic, which will tell you whether it's likely that this plaque will rupture. When a plaque ruptures, typically it creates a myocardial infarction, so that's a very severe event. And the clinician can go here through all of the different lesions and see the properties of those lesions, because right, it can be that the lesion maybe is not that severe anatomically, so it's not, the blood flow is not very constricted, but the plaque may be very vulnerable. And finally, we have a calcium scoring. This is basically an overall score describing how much calcium there is on the different vessels, main vessels of the patient, of course, also overall for the patient, which is a very important risk predictor. So the higher the calcium score, the higher will be the risk that the patient will have a certain event in the next 1, 2, 3 years. So this is an application which is currently at the prototype level. We hope to have it as a product soon. But yes, it allows the clinician to have a very nice and also very precise overview of the coronary artery disease to then decide, right? Once you have had a CT, maybe this just as a background information, the clinician can decide, okay, the disease is not very severe. He will prescribe some medication. He will prescribe, of course, lifestyle changes for the patient to reduce his risk of future events, but there's no need for an actual invasive treatment. If there is indication that invasive treatment is needed, and by invasive treatment, typically we refer to placing a stent. So that's called a PCI procedure, where you go inside the patient with a catheter and you place a stent to basically restore the blood flow. then he will refer the patient to invasive angiography. So that's a different type of imaging where patient is on the table, imaging is done live, and you also do then the stent deployment if needed. So now going back to how the system looks behind the scenes to be able to generate, to have this application that I just presented, we have a series of AI models which are being run in a sequential order. So starting from the 3D CTA data, something that maybe I didn't mention. So the CT angiography exam produces a 3D volume, right? So it's going to give you a 3D data set where, of course, the heart is in the middle of the acquisition, and then you can look at and inspect the coronary arteries. So you see in the first step, the pericardium is being detected. So that's the outer layer of the heart. Then we segment the different chambers of the heart. Then we detect the ostia. Ostia means the start of the, maybe if I go on, so that's really the start of the coronary arteries, basically where the coronary arteries bifurcate from the aorta. Then we detect the center lines of the coronary arteries, and we do the labeling of the different segments. Once we have this, of course, the next step is to really go into the detection of the disease. So here we actually have a multitask AI system, which again takes as input the 3D CT volume. It has an encoder, it has a latent representation. So this is, I guess, something very, very typical for a deep learning model. And then actually it has different branches, right? So that's why it's called a multitask system that basically detects different aspects in parallel. The important thing is, of course, we could have done them also separately, but by having a single model addressing all of the different tasks, the advantage is that basically these tasks which will learn from each other and basically will force this encoder and the latent representation to contain information on all the different tasks, because these are basically interdependent. Right. So on one side, of course, most important, you have the disease. We detect the stenosis. We detect the stenosis grade, but at the same time, we also detect maybe possible artifacts. Right. So, again, a side comment: CT angiography is a very complex acquisition. Right. You have to you want to generate a very clear and very high resolution image of the heart, but the heart is beating. Right. So while the patient is on the table and the acquisition is being done, the heart is beating. So then you have to correct for this motion of the heart while the acquisition is being done, such that in the end, you don't see any such motion artifacts. So, of course, in certain cases, in rare cases, such artifacts can still appear. And importantly, such artifacts may be mistakenly labeled as being disease, right? So then it's important to have this multitask system which tells you, okay, is it disease or is it an artifact? If we would treat them separately, maybe yeah, we would have conflicts in the detections. And of course, the final output, the most important one, is the segmentation. So really showing you how the vessel looks like and how severe the disease is. So this was basically using CT. What you see here is the next step, what I was talking before. So once the patient has gone through a CT, if the disease is considered significant, or there is a high risk of it being significant, the patient is referred to the cath lab. The cath lab, maybe I can restart here the video and pause it. So basically here in the cath lab, the patient lies on a table and you have this C arm. It has like a C shape where basically it will generate 2D images, right, of the heart from different angulations. And you can see how these different images of the coronaries are being taken from different angulations. You can see also how this image, basically how the vessels move in time. So this is a 2D plus time acquisition, where again a contrast agent is being injected, because only the X-rays can only see the contrast; they cannot really see the blood. So that's why it's important to use properly contrast agents such that the entire tree is visible. And then here we can again reconstruct the full tree and again support the clinician in deciding whether a stent should be placed or not. So this is another project which is ongoing, and hopefully sometime in future we'll also have a product based on this. Then another application refers to cardiac MR. So right, what I was talking before, CT and angiography, these are basically based on X-rays. So there is a certain amount of radiation. The advantage of MR is that there's no radiation involved, right? So there's really no downside to the patient. Disadvantages, I know, maybe some of you have had an MRI study before, so it takes a lot of time, several tens of minutes. So again, as a side note, I don't have it here on the slides, but one of the really core activities of the group at Siemens is to try to reduce the amount of time a patient has to spend in the MR scanner, such that you can have more patients being scanned every day. Also, MR has a lower resolution compared to CT and angiography. That's why typically with MR, you're not looking at the coronaries. So the coronary arteries, what I was talking before, they have at the ostium a size of, I know, a diameter of 4 millimeters. And then when you go down, it goes to 2 millimeters, 1 millimeter. So you really need a high resolution for them to be well visible. Cardiac MR has a resolution which is a bit lower than CT and angiography, but still it's very good at measuring, at inspecting the whole heart. And you can see here, again, it's a multitask system. Again, it may look at different tasks and different images of the MR scan. And MR imaging in itself is a very active field of research. So there's very different ways of acquiring the images or of generating the images. And you can see here just a few of them being listed, like sign acquisition, T1, T2. All of them will generate different types of images where you can, on some of them, you can see the blood better. On some of them, you can see different properties of the myocardium. So that's the heart muscle. And basically, by analyzing all these different types of images, you'll gain a lot of insight into how the heart is functioning, right? So one thing is the function. So basically, a core aspect of the function is really the ejection fraction. So basically, when the heart beats and when the heart contracts, how much of the blood inside the heart is actually ejected, right? So a normal value is maybe at 50, 60, 70%. But then if the heart is diseased, it will go down a lot. So the efficiency of the pumping goes a lot. So you want to understand this and quantify it. And then the other types of acquisitions like T1, T2, they will give you a lot of information on different diseases like, myocarditis, cardiomyopathies, myocardial infarction even, basically when you actually get a myocardial infarction. So basically when one of the coronary arteries gets blocked, what happens is that part of the heart muscle will no longer receive blood. So basically it will no longer receive oxygen and nutrients. So then if you don't restore it very quickly, that part of the heart muscle dies. So then you will end up with a scar on your heart, and then the heart will not beat correctly. And basically with the MR images, you can very well understand all of these aspects. There's also the ECV quantification, that's in short for extracellular volume inside the heart, and that's a very good predictor of the risk for future events. So yeah, this is another activity that we have been working on. Then another one is the so-called AI rat companion. So it's again in the field of cardiovascular diseases, but basically here we don't start with an acquisition which is, let's say, focused on cardiovascular diseases, but you start from a chest CT. So the chest CT is one of the most commonly used exams in general in clinics, because patient may come in with some symptoms, with chest, with some issues, and basically where the clinician cannot really determine what is the cause. So then he will order a chest CT, which will do then a screening of various conditions, right? It can look at cardiovascular diseases, but it can also look at other things. You see them listed here on the left side, like looking at the airways, looking at the lungs, looking for nodules, looking for fractures. So anything that can be seen in this image, in this chest CT, right? There are the bones, there are the muscles, there are the lungs, there are the arteries, and so on. So when you have such a chest CT, there's a lot of information in there. And because there's so much information, it's also very easy for the clinician to miss something. So by having then an AI system look at this image and really look at all of the different aspects that are of interest in the CT exam, you can help the clinician a lot in avoiding missing some important things. And especially, it has been shown in the past that basically cardiovascular findings in such chest CT exams are really missed quite often, right? So in a study that we did here, we saw that actually AI had superior diagnostic performance compared to radiology reports prepared by human readers. Right, you can see here, for example, for coronary calcium, the AUC increased a lot. Also for detecting aortic dilatations, the AUC increased a lot. Right, so it shows that AI can then help. Of course, we know, right, clinicians are also under a lot of pressure, right? So they have to go through a lot of data, go through a lot of such exams every day. So then looking routinely again and again and again at these exams, I would say it becomes quite easy at some point to miss some things. And of course, the AI will never get tired, will never be influenced by such factors like a human. And then, of course, we see such results where the AI model can actually perform better than a human reader. And even more than this, still referring to the chest CT exam used for screening, we have shown that the findings that we extract from this image actually have predictive power. So, for example, one of the measurements is the left atrium volume index, or in short, LAVI, and the value of this index determined using an AI model has predictive power. So, for example, it has a very good AUC in predicting the onset of atrial fibrillation after 60 months, right? So predicting in future that atrial fibrillation will become an issue for the patient, or that heart failure hospitalization will become will be present after 5 years, right? So it's a very valuable data, not only to detect what the patient has right now, but also to see what the patient could develop in future. Okay, so this was basically, I would say, at the second level. If we recall I think the second slide that I had, where we're using AI at different levels, everything that I've presented until now was at the second level, where we're processing the images, processing the medical data to detect different things and to help the clinician. Now we're moving to the third level, the one of the digital twin, where, of course, in this case, focusing again on cardiovascular diseases, the most important thing is the heart. So then the goal was to really create a digital twin of the heart. So basically a personalized model, a personalized computer model, which reflects really the real heart of a patient. And of course, the advantage of being able, or of having such a model, is that if it's really accurate and it really reflects what the heart of the patient is, you can then try out different treatments on this heart before doing it actually on the patient, and then decide, okay, what's actually the best treatment option for this specific patient, right? So not, probably, right, in the medical field, there are guidelines in all the different domains, right, where they say, okay, if the patient has this, you should do this and this. It's not an exact science, right? So it's always some of the treatments are good for some patients, are not good maybe for a minority. And really by having such a personalized medicine approach where you really try out different options on the heart of that patient, but of course in silico and not in reality, will be able to give you in the end a better outcome for the patient. Of course, now for the heart is very complex, right? So it has, I would say, it has three main aspects. Of course, the starting point is the anatomy. So you start with some medical image, be it a CT or an ultrasound, and then or a cardiac MR, and then starting from the anatomy, where of course you use AI heavily to extract all of the anatomical models, then you have three aspects which influence each other. So first of all, there's the electrophysiology. So basically that's the electrical impulses which trigger the contraction of the heart. When the contraction of the heart is triggered, you have the biomechanics, basically really the mechanical action, the muscle contraction. And as a result of the contraction, you will have the circulation. So basically the blood will be pumped out from the different chambers of the heart into the body, into the arterial system or into the pulmonary system. And of course, all of these things influence each other. So to be able to really have a digital twin of the patient, you need to model them in parallel and model the interaction between them and to model them in time and have really high fidelity models for all of these aspects. And then, of course, as I was saying, if you have this, then you can try different treatment strategies for different pathologies. And here are just a few examples, like atrial fibrillation is one, where you could use the model to identify different ablation targets to basically terminate the persistence fibrillation. In case of VT, ventricular tachycardia, you can identify the minimal ablation targets, or you can think of this rather new approach where you use cardiac radioablation, right? So radiotherapy, is typically used in cancer treatment, but it has been shown that you could actually use such radioablation for the heart to actually focus the radiation on the VT exit site and basically try to solve this issue for the VT patients. And finally, in case of dysynchrony, so dysynchrony is something that happens typically when the patient has had a myocardial infarction. So what I was talking about before, where when you have a myocardial infarction, maybe part of the heart muscle dies, right? So that part of the muscle will no longer contract. So then it will no longer conduct the electrical signals well. So then basically everything, is kind of distorted. So, some of the patients will have very severe symptoms. So then what you want to do is a CRT, cardiac resynchronization therapy. But again, CRT, I know, has success rates maybe at 70, 80%. So there are 20, 30% of patients which actually, do not get a good outcome of this treatment. So then by using the computational model, you could actually optimize, or you can optimize, and we've shown that it really does help by using this digital twin to determine the best treatment strategy. Okay, right. So cardiovascular disease, as I said, it's the most important cause of death worldwide. I won't read the numbers, but they are quite impressive. And what I wanted to also show is actually an activity that will again hopefully soon reach a product level and will be used routinely in patients. Is right. So in the coronary arteries, I was talking before about doing the anatomical assessment, so really understanding where the lesions are, understanding when you want to put a stent or not. So by the way, you can see here some diagrams of the stent deployment where the catheter is introduced, and then you have these plaque here, the deposits, and then you inflate a balloon, and basically the stent is inflated, and you restore the original lumen of the patient. So to decide whether you actually need the stent or not, around I would say 2 decades ago, you would take this decision just anatomically. So if the stenosis is more than 50%, you would put a stent. But then it was shown that actually this pure anatomical criterion is not enough, right? So it was shown that either some patients which didn't get the treatment had a bad outcome, or some of the patients actually wouldn't have needed the stent. So then the clinical guidelines changed, and it was shown that you can take a better decision by measuring invasively the pressures inside this artery. So basically, you measure you go in with a sensor, you measure the distal pressure, PD, you measure the proximal pressure in the aorta, you do the ratio of the two, PD by PA, and if the ratio is lower than 80%, so lower than 0.8, you would do a PCI procedure, so you would put a stent. So basically, if the drop in pressure over the stenosis is larger than 20%, you would have to put a stent. And it was shown that by taking a decision based on this criterion, the patient outcome on the long term is much improved, right? Because, I mean, in the end, and this is something which is the same for all of the medical procedures, what really is the final criterion for deciding whether a procedure is good or not is looking at the long-term outcome. Of course, in some of the cases, you can see the outcome immediately after the intervention, but of course, you have to also look at the outcome on the long term. Now, the disadvantage of this procedure is that you have to go invasively with a sensor. You have to, this sensor, you can only use it for one patient. It's quite costly. It's, I think, over 1,000 euros. And yeah, it makes the procedure itself longer because you have to insert the wire. You have to also administer some hyperemia-inducing drug to increase the blood flow and so on. So then the goal for us was really to, this is just one slide showing, okay, where CT was in, I know, 50 years ago, what type of images it could produce at that time when it was introduced, and what type of images it can produce today. So our goal was actually to be able to compute this index, right? This ratio, which is called FFR, fractional flow reserve, compute it from CT images. Yeah, I think I'm gonna speed up a bit. So, and I've already talked about this, right? You have the CT exam, you have the model of the 3D coronary arteries, and then what we came up with was a computational model which will simulate the blood flow in the coronary arteries, of course, basically in the whole cardiovascular system, but with a focus on the coronary arteries. And the goal is actually to, again, to model the blood flow inside those arteries in a personalized manner, right? So personalized, what does it mean? It means not only to have the anatomy of the patient, but really to also model to have the exact same flow and the exact same pressures inside the model that are actually present in the real patient. And for this, you have to model all of the different things that happen inside the coronaries. One of them is the coronary autoregulation, where this is a system which ensures that the myocardium always gets the right amount of blood, right? So for example, if the patient does physical exercise, the blood flow will increase a lot. Typically, it can increase by 4 to 5 times, right? Because the muscle, the heart, has to do much more work to push much more blood through the body, right? To make sure that the patient can sustain the physical effort. Then the heart muscle itself needs much more power. So if it needs much more power, it will need more blood to get more oxygen and more nutrients to be able to do this. So this is called the coronary autoregulation, which you can see here can increase the blood flow by an almost 5-fold amount. Now, the problem is if you have a stenosis, if you have a constriction there, then actually this increase in blood flow is reduced. You see, if the stenosis is 50%, the reduction is minor. If it's 70%, it's already significant. If it's 90%, basically that patient can almost not do any physical exercise, right? Because he will immediately get angina, the heart will not be able to pump properly and will not be able to sustain the physical effort. And again, all of these things have to be modeled correctly. Then which we did, and which we showed that okay, it works well. We can actually do this in a personalized manner, but the problem is a computational model where you solve nonlinear equations. It takes quite a lot, right, to solve it numerically, because it's nonlinear, because it has partial differential equations. You have to solve it numerically, and the numerical solution always takes a lot of time. So then our goal was actually to come up with an AI model that can produce results in real time. Right, so have an AI model which is kind of, let's say, a surrogate model for the physical model. So it will learn from the physical model. It will produce the same outputs, but not in a matter of minutes or hours, but in a matter of 1-2 seconds, so almost in real time. You know, right? When you have a machine learning model, the training may take quite a lot, but once you have the trained model and you do the inference, that can take place almost in real time. Of course, at this point, we didn't have that many patients, right? So again, to train AI model, you need a lot of data sets. So our strategy here was actually to generate synthetic data. So we developed an algorithm to generate synthetic coronary arterial trees. We then ran the computational model on the synthetic trees. We computed all the measures we wanted, the flows, the pressures, FFR, and then we trained the AI model to actually predict exactly this using a deep neural network. The results here were, I think, very good. The ML model was able to reproduce almost perfectly the computational model, so the CFD results. And you can see here it actually reduced the runtime from around 5 minutes to around 2.5 seconds. Right, so I think this is the final video. I'm just gonna start it. So this is again a prototype that we have developed, and where basically you have this 3D CT volume. You first run the AI models to detect the center lines. Then once you have detected the center lines, you run the AI models to detect the lumen. It will also use the myocardial mass, which is an important input to personalize the model. Then the user attempted to compute FFR and actually got 2 warnings. And at this point, for this prototype, actually the user was asked to mark the significant lesions to be able to actually have a higher resolution and a higher fidelity in the lumen around the lesion, because these are actually the most important ones when predicting FFR. So that's what you see right now. The user goes through the 2 lesions which were considered anatomically significant and actually marks them with a proximal and distal location. And once this is done, the user can compute FFR, and you will see it here. Basically, there's also color coding where 1 means, okay, it's healthy, and then red means it's diseased, right? So you can see here that there is a lesion which actually leads to a very low FFR, so which would mean that this lesion should actually be treated invasively. So you see here just some examples of some coronary trees where here FFR is below 0.8. You can see here the lesion. Invasive is 0.76. What you see on the left is the computational model. On the right is the machine learning model, which produce identical results. So basically, yeah, that's it from my side. Hope you enjoy the presentation, and of course, happy to take any questions that you might have at this point.
Yeah, thank you very much, Lucian. Sorry, my cold is still there. For this very nice presentation. Are there any questions? So if you have a question, you can either unmute yourself or you can ask them in the chat. So while we are waiting, I have one. When you look at making such a digital twin for, say, a patient like me, what would you need from me to make a digital twin?
Yeah, so for and most important is the anatomy, right? So we need some medical images. I think it can be CT, it can be ultrasound, it can be cardiac MR, which basically show you the heart such that you can have the anatomy from there. And then additionally to this, we need some more measurements, like for example, for properly modeling the electrophysiology, you also need an ECG recording, right? So ideally a 12-lead ECG, because this will tell you then, okay, of course you don't measure, you measure the ECG on the surface of the patient, right? You don't measure it on the heart, but still by having this data on the surface of the patient, you can infer how the electrical impulses and electrical signals are on the heart, which will then allow you to model this properly, right? So basically this is kind of like an, let's say, optimization problem or an inverse problem. You have the ECG signals, and by using the information from the measured ECG, you are tuning or calibrating different parameters of the model such that your computational model will produce the same ECG as the one which was measured from the patient. So in short, to answer your question, basically beside the anatomy, there will be some other non-invasive measurements which will be done for the patient and which will be used to calibrate different parameters in the models such that these non-invasive measurements are matched by the digital twin model.
Mm-hmm. So in summary, basically I have to get a scan and maybe an ECG, and then
maybe some blood pressure measurements with a cuff, right? As you have them typically when you have a standard appointment.
So one question about the underlying model, is that a computational physiology model? So that is a mechanistic model.
Exactly. So for all of them, both electrophysiology, biomechanics, and circulation, these are all physics-based models.
Could you say a bit where the model comes from? So which group made the model?
So basically, I think the electrophysiology and biomechanics model, these are models developed in Princeton in the US. I think you can see here some of the authors, and I think there's been a publication, a book about this. And the circulation model here, I think this, I also worked on this part, and there are also some other colleagues from around the world which worked on this part. And I think, basically this part of the electrophysiology plus biomechanics, also the team in Germany, the Siekmann team in Germany, which I think will also be part of the, there will be an EU project also with Sandra and Ivan starting soon. It's called Target, and they are also part of the project, and where actually this model will be used in stroke research.
Thanks a lot. So I see that Ivan has raised his hand, so he wants to ask a question, I guess.
Sorry, it's just a quick question. Thank you very much. I'm very interested in the presentation. Even though it's not the first time I see all the things that you have presented. I always end up mesmerized with all the advances on this. So my question is related to I mean, those models that you presented around being able to predict the risk of developing AF. I don't remember the other condition in such a long term. So I think you mentioned 60 months. So that's pretty much 5 years. So my question is that how do we know so those factors that you extracted or markers there are really predicting, the risk of developing AF in such a long term. So in 5 years, many things might happen. So for instance, I don't know. I guess that the patient. So the other factors might have influenced that outcome during that period. So have you considered all of that? So potential intervention that have been to the patient, or changing in habits, or changing, I don't know, lifestyle or things like that might have influence on the outcome.
Yeah, I think this was, I would say, more like a proof of concept study, right? So you can see here also the number of patients was not that high, and I would say, it actually didn't let's say, take into consideration really also, let's say, kind of like a subgroup analysis. Okay, maybe, yeah, indeed, this index is very powerful in predicting this, but if you also take into account, okay, how lifestyle changes or other interventions and so on, you can for sure stratify it even better, right? So this was really like, I would say, a proof of concept study where we had this data and patients were really followed up over more than 5 years. And we could there observe that by taking the value of this this LA volume index at the baseline, you could actually very well predict who would develop AF or not, but not really, yeah, taking into account other factors which maybe, yeah, have also helped or would have not helped in improving this prediction.
Okay, thanks. Yeah, very useful.
Yeah, thank you.
So I've seen that there's a question in the chat from Carla Mena. So she asks, following on from the digital twin question, what have sample sizes for building those models been? Has the imaging modality USS-CT MRI chosen been found to affect the resulting model?
Yes, I mean, we know, right? If we refer to the imaging modality, yeah, we know ultrasound has a lower resolution, and yeah, again, it's also a bit of operator dependent, right? How the probe is being held by the clinician during the exam, and depending on the properties of the patient, the image quality can be lower or higher. So of course, when you use, for example, cardiac MR, you can typically create a more reliable model, right? Now, I think, right, so of course, yeah, because the answer is yes, there are differences between the different medical imaging modalities, but as I said, right, cardiac MR is, yeah, is not, let's say, not that routinely done in many patients, whereas ultrasound is really something that every patient with a cardiovascular disease, when he's admitted to hospital, receives such an exam. So that's widely available. Now, in terms, I think there was the other part of the question, the sample sizes for building the model. So, right, I mean, these are physics-based models. So here the goal is really you build a model, you have your strategy or the framework for personalizing the model. So what I was talking before, to calibrate some different parameters of the model such that you match the invasive measurements. So here I would say the model itself is not, it's actually not relying on a training data set, right? So that the actual patient data that you have in this case is used for validation. Or in, let's say, maybe in a more extreme case, you have a certain data set that you use to fine-tune your calibration procedure. You show, okay, it's fine, and then you come with a different test set and you confirm that your calibration procedures are as they should be. But in essence, there's no real need when you have physics-based modeling. There's no need for a large training data set.
Okay, I hope this answers your question, Carla. There's another question in the chat by Sutsodiman. Has any of the data sets used, or the subset of the data sets, have they been made publicly available so that other researchers can use them too?
I mean, for the data, that's something I actually didn't mention, right? So inside this group, there's one group. It's called the Big BDO, Big Data Office team, which just handles, let's say, data-related aspects, right? So we know there are publicly available data sets, but in many of them, the licensing states that you are actually not allowed to use it for product development. So right, anything that we develop, any product that we develop now, right, research is fine. You can do research, you can publish, that's all fine. But when you want to develop a product, and of course, then you have all the regulatory aspects behind it. You have to go to the FDA, for example, if you're in the US, then you have to show, okay, the model was trained on this data, and we had the permissions to use this data, and so on. So we have a special, a dedicated group that actually handles all of these aspects, right, such that we have the right data, we have all of the paperwork, have all we need that covers the development of products. And in most of the instances, actually, we get this data through dedicated contracts, right, which actually do not allow us to make it publicly available, right? So it's all private data that, okay, there's an agreement that we can use it for certain developments, maybe also product development, but it's never linked, or it's typically not linked to having it publicly available. Right. So unfortunately, this is the reality, right? It's medical data. Of course, we're only receiving anonymized data, right? So we don't know any of the personal, I would say, identifiers or personal information of the patients, but still it's data from patients. So then we have to be very strict with whatever is imposed on the data set when that data set is shared with us.
So I hope that answers your question. There is one more question from Sandra.
Yes.
Yes, just a brief one, and yeah, not exactly about the presentation itself, because yeah, I like Ivan, I know quite a bit of it already, and it's very exciting, and I know I'm gonna enjoy the next 5 years. But yes, it's basically around kind of the access. I know it's not your research team that obviously knows the answer to this, but how close is this at the moment? The things that you have presented today to application in clinical practice, and how much access there is, how much it closes the gap in terms of, health access from all the different backgrounds.
So I think I guess everything that I've presented here is available or can be made available as a research tool for clinical use, right? So there are special let's say workstations. For example, in CT, there's a workstation called Frontier, where if you have a Siekmann CT scanner, you can acquire the workstation, and then on that workstation actually have all of these research prototypes, which a clinician can then use for doing research. Of course, it's only for research, right? Because there's no approval for it to be used as routinely, but many of them are actually, I cannot now go into the specifics, but many of the things that I presented here are actually under productization efforts, right? So that's basically the transition from the prototype, which is already there in the clinics, and clinicians can use it for doing research, such that we really make the transition to product.
Thank you.
Yeah, thank you.
Yeah, I don't really see any further questions at the moment, so this might be your last chance. There are no further questions. I would like to thank you for presenting in our seminar. I enjoyed that a lot as well.
Yes,
and
thank you. Thanks so much
have
again.
a good day.
Yeah, thank you. Bye-bye.
Bye-bye.
Bye, everyone.